All right, so this is a compassionate way of engaging a community around the issues of substance use disorder, HIV, hepatitis C. And as we all know, the COVID-19 outbreak that gained momentum throughout the United States in the 1920s and have come back in a vengeance now, it highlights how socioeconomic and racial disparities impact the health of people. This fact goes beyond genetics or limited access to medical care. The roots of disease can consistently be traced along the tragic history of toxic stress experienced, often generationally, by marginalized and impoverished people. Socioeconomic stress has been well established as a contributing factor to the development of chronic diseases like heart disease, diabetes, and asthma. Now, my patients taught me just how devastating the health impact of socioeconomic hardships can be. As you all probably know, in March 2015, I was the only doctor in Austin, Indiana, a city of 4,300 people in Scott County, Indiana, just off I-65, between Louisville, Kentucky, and Indianapolis, Indiana, when it became ground zero of two unprecedented epidemics that had their roots in the 1980s. One was the national opioid epidemic, and the other was the worst recorded HIV outbreak among people who use drugs in the nation's history. These two deadly epidemics that had been brewing alongside each other for decades finally boiled over in Austin. And I know that this is close to your all's hearts as well, because West Virginia is in the middle of very similar crises. A lot of the same demographic groups. In fact, a lot of the people that I take care of in Austin, they migrated to Austin out of Appalachia. My family as well migrated out of Appalachia. And I grew up in that culture. My parents were poor. My mom was from some squatters on the Ohio River, actually, and she was able to overcome a lot of that. So sharing a lot of the same demographics, a lot of the same issues, and I know you all probably been following this closely, and even some have made trips up to Austin to see what's been going on there. So again, we're dealing with overlapping issues of the opioid epidemic, demographics, public health policy, and then infections like HIV and hepatitis C. Austin, it's again located right off of I-65 between Louisville, Kentucky and Indianapolis, Indiana. It's a town of 4,300 people. Scott County itself has about 24,000 people, but there's a high rate of poverty, unemployment, chronic toxic stress, adverse childhood experiences. In fact, Indiana had been ranking 5th in the nation for adverse childhood experiences. In 2013, Scott County ranked 2nd in the state for childhood abuse and neglect, and that doubled. The incidence doubled between 2011 and 2014, leading up to the HIV outbreak. So these are all, indicators that something, pretty bad's going on. Alongside that, we really didn't have any access to addiction services. Indiana, as you can see, ranked near the bottom as far as access to addiction professionals. And then Scott County fared a lot worse than the state as a whole. So, we're looking at the public policy. When I first got to Austin, the school systems would not allow anything other than abstinence-based sex education. Really couldn't talk much about harm reduction. It was viewed as enabling people, and no real access to like syringes. Condoms were a big taboo. So it was a really a difficult situation to come into and try to bring with me and the wealth of evidence that show that these public health measures make a difference. So that's where we were starting from when the HIV outbreak happened. And at that time, there was about a quarter of the population that was misusing prescription drugs, and about 15% of the population was actually injecting prescription drugs. And the biggest obstacle was simply finding people. These are people that are living off of the grid. They didn't want to be found out, very highly stigmatized. They didn't want to be known by medical professionals because they'd been treated so poorly in the past, or even be known as someone who was using drugs because it's illegal and they didn't want to be arrested. And so what I have developed over the years is kind of an understanding that most people are wanting to do something positive in their life, but they're unable to for different reasons. And I really believe that in order for people to make healthy decisions and to have the opportunity to be prosperous, in their life, the first thing that needs to happen is that their basic human and safety needs need to be met. And overlapping that to address the socioeconomic circumstances that they live under. Sometimes those circumstances are so overwhelming that no matter what they do, they can never feel like they can overcome those, and they end up developing a sense of learned helplessness. And then adding to that, just having access to resources to be able to make healthy life choices, because people can only make choices from the options that they have available to them. For example, sterile syringes. If people don't have access to sterile syringes, they don't have that option to make a choice to use a sterile syringe. And oftentimes they'll share or reuse syringes, as you all know. So overlapping these things, that's when people have the agency to be able to start making those healthy choices, to be able to have access to health, prosperity, and well-being. And we didn't have that in Austin. In fact, there wasn't even testing going on. The only place that was free to get testing was the Planned Parenthood in the community, and that was closed due to funding issues. And so someone with HIV, they moved into the community around 2011, it looks like, and HIV started to slowly spread in the community. And it finally reached a tipping point. And we had a very rapid rise in the number of people contracting HIV, mostly through syringe sharing, but also through sex. But since there wasn't any testing, we were behind the curve on this. Testing wasn't done until you can see here with the red line starting to slowly catch up over time. So we were behind this because we didn't have access to people who were injecting drugs, and they weren't being tested. And if we would have caught this, much earlier back in, say, 2013, if we had access in testing people, there's a chance we could have prevented this entire tsunami from overtaking the community. Instead, we, ground zero of this tragic HIV outbreak. This is basically what happened all in one graph. There's a lot here, but one of the first things that happened was Governor Pence, under a lot of pressure, decided that he would listen to us and give us access to the syringe service program that we needed. But he designated only for Scott County at the time. But we were able to have access to that. Shortly after that, 5 days after, actually, we opened the first HIV clinic at my office. I decided that my primary care office needed to have access for people who inject drugs, including people living with HIV, hepatitis C, and those other comorbid issues. So we opened that, and then the syringe service program opened a few days later, a week or two later. And you can see the numbers quickly leveled off, combining treatment with testing and linking people to care and getting them access to harm reduction strategies like the syringe service program. The outbreak quickly leveled off. Now, at the time, up until then, from the entire time that I've been practicing there, since 2004 to 2015, we'd only diagnosed about 5 people with HIV. But in that 1 year, we diagnosed 181, which represented about a third of all the new cases in Indiana. Here's the demographic breakdown. It was mostly young people, mostly injecting drugs. Early infections. So we did catch this still relatively early. Most people had not developed AIDS at that point, and most people were co-infected with hepatitis C. We had seen that coming from about 2010-11 through the outbreak. We saw increasing numbers of hepatitis C. So that wasn't surprising either. Now, the biggest challenge that we had was just simply finding people, the same factors that had cut people off from community and hope and opportunity had also cut them off from the healthcare community. And really the overriding sentiment was that, these weren't people. These were drug addicts, homeless people, prostitutes, and they had all these names and labels, and basically, dehumanizing them and assuming that they were unwilling to engage in care. They were accused of being lazy and criminal and degenerate and unintelligent, not able to take care of themselves. And even some people advocated withholding, life-saving treatment for them, that they weren't worth saving. But what I've found working with people in these situations is that when approached with respect in a way that feels safe to them, once they're given the resources and opportunity to make healthy choices, virtually everyone that I've worked with are willing to take responsibility for their own health and the health of their communities. The key is to provide people with a safe bridge to those opportunities. Now, you've probably heard the word syndemic, but just to be sure, thought I'd define that as it's the concentration and deleterious interactions of two or more diseases or other health conditions in a location or population, especially as a consequence of psychosocial and socioeconomic conditions promoting disease clusters. Now, it's important because we're not just dealing with a disease, we're dealing with a cluster of overlapping psychosocial, socioeconomic, cultural, public health, stigma, a lot of different things go into this. And so if we're not willing to see that bigger picture, we're going to miss the opportunity to actually take care of people instead of just diseases. The CDC has recognized this. A lot of grants are targeted to a disease, with a specific outcome. You can get a grant to deal with HIV. You can get a grant to deal with hepatitis C. You can get a grant to deal with housing, or name the issue. But just dealing with these things one at a time never gets us to where we need to be, because these are complicated issues. These are human beings with multiple needs, and not just, a person isn't just a person with HIV. They're a person with HIV that lives within the context of a whole host of other things. So just dealing with things in silos leads to poor collaboration and ultimately failure. And success comes through synergistic care, wrapping people in the care that they need. Instead of addressing the HIV, addressing the person, and that person is very, is very much an individual with individual needs, and it requires a team to come along and work alongside them. So synergistic diseases in a syndemic requires synergistic multidisciplinary care. So how do you do this? Combine prevention, recovery, and treatment. And these are the things that we did, but they overlap, really well. In my area, we have MATEC, which is the Midwest AETC. In your all's region, it's Mid-Atlantic AETC, and it's AIDS, HIV training. They do hepatitis C and HIV training. It's a great resource. They have funding to help clinics and primary care providers and communities know how to take care of people living with HIV, understand the disease of HIV, how you contract it, how you don't contract it, why you shouldn't be scared of it, those sorts of things. And so they can do a lot for a community. They can also do a lot for training staff and primary care and support, people trying to take care of people with HIV, living with HIV. Similarly, there is an organization that receives funding to do the same thing for addiction. In my area, it's GLATC, the Great Lakes ATTC. In your all's, it's Central East ATTC. And they have a lot of resources to help clinics and communities understand addiction and people living with substance use disorder and recovery, develop recovery services, develop the infrastructure to be able to take care of people living with HIV, even developing MAT programs. Of course, ECHO, huge fan of ECHO. I wouldn't have been able to provide HIV and hepatitis C services in my community if it wasn't for ECHO. At the time, as a primary care provider, the state would not allow me to treat my own patients living with hepatitis C, for example. But we used ECHO, and you know, my patients don't even have a car. How are they going to travel to see a GI doctor or an infectious disease doctor? But they could walk to my clinic, or we could go pick them up and take care of them. So we worked with the state to develop a way that we would count ECHO as that consultation. And so my participation with ECHO allowed me to treat my own patients living with HIV. And as you all know, it's a great model. Instead of patients moving to specialized information, the specialized information moves to the patients, and it's replicated out so that impact, one infectious disease doctor can actually take care of multiple communities and many more patients than they would ever be able to take care of by themselves, working within that team through the technology with Project ECHO. And I don't need to champion that because I'm preaching to the choir here with you all being on this. Obviously, MAT, there's a lot of resources available to train people, to help people feel more comfortable, providing access to medication assistant treatment. This is just one. I like this one because it also links you to a mentor. So if you have questions as you're seeing patients, you have an expert mentor that you can email, you can set up a Zoom call or something to talk through those cases. And then of course, collaborations, because we can't do everything ourselves. We need people helping alongside. You know, I can treat somebody's primary care, I can treat their HIV, but I don't have time to really sit down and really dig into the ACEs, into the trauma, whatever it may be. So having, you know, behavioral health, they're now co-located at my clinic with Centerstone Behavioral Health. We have recovery centers where I can now go and take care of patients at our recovery center and get them off of the street and into recovery, and then transition them into the care that they need from there. Obviously, the Department of Health is a big partner, both from funding, but also resources, and then public policy. AIDS organizations and other organizations who target different conditions and diseases and those sorts of things are great partners to come in alongside us and really help surround the patient with everything that they need. The recovery community, community coalitions, insurance navigators, Empower, they're a youth coalition in our community that's become a partner as well. All of this fits into what's called a recovery-oriented system of care, or ROSC. And it basically defines recovery for each individual community, because every community is different. And ROSC may look different for each community, but it helps define what recovery is for that community. And then it allows every organization across all sectors to buy into the same idea that recovery is available and accessible to anybody that wants at any time. They could go to the sheriff and ask for help to enter into recovery, or to a school, or to a church, or to the hospital, because everyone has bought into the same idea of what recovery looks like, and everybody decides to work together with that. And of course, harm reduction has to be a part of it to keep people safe, both from diseases and also death, because we can't help people who are dead, and that brings with it a lot of trauma to families and communities as well. And then I don't want to leave out our faith-based partners, because oftentimes they're very passionate people, hardworking, who's willing to go the extra mile to just sit with somebody, or to drive them to a recovery center, or help them find food or water, or food for our soul. They give them a free meal once a week. Some places let people just come hang out there, or shelters to help people get off of the street. So partnering with them is important. what happened in Scott County, it was really the canary in the coal mine. It had happened there first, or got the attention there first, but it's really happening all across the country and in most communities. There was a recent Lancet article that showed that Scott County could have prevented over 90% of the HIV cases if we had simply been screening for HIV and linking people to the care that they deserved. This is a graph that I came up with, and I kind of combined Maslow's hierarchy of needs with the information that we now have on ACE, adverse childhood experiences, and what generational trauma does to people. And you're probably familiar with Maslow's hierarchy of needs. As your basic lower needs are met, you can move up the hierarchy to focus and put your energy towards higher needs. So basically, the idea is if somebody doesn't appear to be trying, it's probably because their lower needs aren't being met. So instead of judging them, they're not trying. Maybe we could refocus that to look at what needs are going unmet in their lives. And if somebody doesn't feel safe, they're probably not going to come to the clinic or take their medication or X, Y, and Z. So providing a way for them to feel safe, or for them to feel like they belong, that they're welcomed, that it's safe to come in and access care. On the bottom side of that, obviously it moves in the other direction. If somebody's born into generational trauma with toxic social conditions, that wasn't their choice to be born into those circumstances. They didn't choose that, and yet they still bear the consequences of where they were born. Senator Sanders recently pointed out that a child born in Fairfax, Virginia, is expected to live 14 years longer than a child born in my county of Scott County, Indiana. 14 years just based on where they're born. And it goes back to these issues, toxic stress and adverse childhood experiences. It disrupts the neurodevelopment, leading to social, emotional, and cognitive impairment, which will lead to risky behaviors that then develop into diseases, disabilities, and other social problems, chronic arrests and such, and early death. So the things that counter that were published in Dr. Adams, when he was Surgeon General, published Community Health and Economic Prosperity Report. And they identified these 7 vital community conditions that foster health, wellness, and prosperity. And without these conditions, people born into that community are at risk. And again, people don't choose to be born into a low opportunity community. And these are the things that we can really invest in as a community, as an entire community, to make the biggest impact and biggest change in people. Because we can provide the best HIV care in the world, but if they don't have a place to stay, they don't feel safe, they don't, X, Y, and Z, they're probably not going to follow through with the treatment as well as they would be able to if they weren't focusing on those lower needs and felt safe. So going through them, very quickly, meaningful work, a livable wage, the ability to build wealth is very important for health and wellness. Lifelong learning. There are evidence-based interventions that schools can implement that offset the impact of ACEs, for example, adverse childhood experiences, help children as they're going through school to build life skills. So they're better equipped to deal with overwhelming emotion and distress tolerance, and to be able to even make a healthcare appointment. Not everybody knows how to do that, but lifelong learning can contribute to that. Obviously, being able to feel safe with humane housing, without concentrated poverty or injustice, toxic stress. So diverse communities where people can be exposed to upward mobility in an easier way. I've heard it said that, if a child grows up without any role models, without a single person in their life that they can look to for inspiration, their opportunities close off. Reliable transportation, if somebody can't get to the clinic, they can't receive the care that they need. So safe, reliable transportation is vital. And then at the core of all of this is just that sense of belonging, that you matter, that you can make a difference. Without that, something dark happens to the human soul. So putting all this together, you can look at the biomedical interventions, behavioral interventions, and then structural interventions. And structural interventions are trying to work within a community and within a state, within the policies to decrease inequity, to enact better laws that protect people's rights to treatment, better education around health, for the public and youth. When our HIV outbreak occurred, people were afraid to sit in the waiting room. They were afraid to go to Walmart because they were afraid that they would contract HIV that way. They just didn't. They were never taught how HIV is spread, and more importantly, how it's not spread. Decreasing stigma and discrimination, and then biomedical interventions, obviously increasing access to care through mobile clinics, telehealth. One of the things we've recently implemented here is to provide our Ryan White eligible patients with tablets that have a cellular signal. So no matter where they are, we can connect with them. Our case managers connect with them, their therapists, they can attend support group meetings or their telehealth visit to make sure that all their needs are being met, providing access to MAT in an integrated way. Again, people have trouble with transportation. We make them go all over the place. Why not provide, one site that they can receive their primary care, their HIV care, their hepatitis C care, their MAT, their, all of that right there. Obviously, harm reduction, like we talked about, screening. If we don't know somebody has HIV or they don't know that they have HIV, we can't do anything about it to prevent that spread or to treat them. And then protecting moms and newborns, and the behavioral interventions with educating people on their disease, the disease process, substance use disorder, what HIV is again, therapy, access to employment, again, to have that meaningful use, the livable wage, and then the social and peer support. We just recently implemented an HIV peer support group statewide and then in the different regions. And it's gone incredibly well. It was something that obviously people were wanting, and it just never had access to it. There's access to recovery support groups, but very little access to HIV support groups. So once we implemented that, it's really gone well, and people feel much more a part of the community, that sense of belonging, and that they matter. So when we did these things in Scott County, really a beautiful thing happened. In just 6 years, the number of people in recovery has increased by over 1,000%. We've developed a system of care that's not just centrally located, but no matter where somebody goes, they can enter into that system of care, which has been very important. And over time, you can see this is data that comes out of our syringe services program. The green line is the number of syringes distributed over time. And of course, there was a rapid increase in the beginning, and that's slowly tapered off as people have needed fewer syringes because of people getting into recovery, injecting less, and so forth. And then the number of people being diagnosed with HIV has dramatically gone down. And then the gray bar is the people entering into recovery. You can see that going up as well. Most of our patients are virally suppressed, 77% here. It's stayed right around there. It goes from 78 to 76, but right around 77%, which I'm told is the best in the state. So the people who we were told would not take their HIV medication and would not engage in care, they are. They're proving everybody wrong, because people are willing to take responsibility for their health if it's provided to them in a way that feels safe, like in a syringe service program. When the syringe services program was opened, 76% of people were sharing syringes. That went down to 22% when the syringe services program opened. And then the people who were injecting drugs using the syringe service program was 86% of people who injected were actually using it. But if you look at the people who inject drugs that live with HIV, that went up to 98%. So that extra knowledge, knowing that they had HIV and wanting to protect other people, it dramatically increased even further. So again, further evidence that people are willing to take responsibility if they have access to those choices. Again, people can only make choices from options that they have available to them. Our hepatitis C numbers, we decreased those by over 76%. HIV, we've decreased those significantly. Again, that first year, 181 or so new people diagnosed with HIV. Last year, we only had one in the entire year. We only had one new case of HIV. So really, what we've come to believe, working within our community, is that communities fail because we keep painting over the cracks in our communities, in the foundations. We're not willing to dig a little deeper and find out what's dividing us, what's keeping us from the health, wellness, and prosperity that we all want. Really, banishing broken people is contributing to that crack in the foundation. It's making that wider. But by allowing people to be vulnerable, to be broken, to not be okay, to share the message that it's okay to not be okay, it allows people to feel safe accessing the care that they need and really the community needs. Because what is a community if it's not the accumulation of everyone living within the community? And people who inject drugs, people that are homeless, et cetera, they're people living in the community. And so their health matters because it adds to the cumulative effect of that community. Our patients are complex. These issues are complex and they require not just one way of addressing the issues. But we live within a system that's really honestly broken. And it oftentimes prevents us from being able to provide the very best care that we know we need to provide for people. And that can feel really bad. That can lead to really moral injury within ourselves. And that moral injury can lead to burnout if we're not careful. But we all started doing this for a reason. And trying to hold on to that reason and find that passion and refusing to be a part of that broken system that addresses diseases and recenter on that person. Because I think if we continue to focus on the person, each person, that's the reason we started doing this. And that'll continue to motivate that passion that we started this with. So I know burnout is a real issue. It often comes from that moral injury of just not being able to do the things for our people that we know is best for them. But hang in there and just stay focused on the people instead of the diseases. And by doing that, we come together not over a community, but combined with a community. And we all have our issues, but working together, we can be a part of a beautiful mosaic that leads to a prosperous, thriving, healthy community. There's a lot of people that came along the way to help in Scott County and help me and help my patients. I've tried to list most of them. I may have forgotten a few, and for that I apologize. But I do want to leave time for questions. And I know you're all aware that our syringe service program got voted down. So I'm hoping that I don't give this talk in a few years and talk about how we've backslidden, gone the wrong direction. But I do want to open it up to questions and hopefully have a good discussion about this.
Thank you so much, Dr. Cook, for sharing your experiences with us today and taking the time to present. It was such a powerful and moving presentation, really. So we really appreciate your time. But absolutely, we're here for open discussion, Q&A. So anyone who has any questions or comments, please feel free to unmute and ask away or chat in.
So this is Judith Feinberg. So Will, that was terrific. It was a moving and terrific presentation. You probably know that we have a new law here in West Virginia that is going to markedly alter access to syringe services. And like Scott County, we're in the middle of a considerable HIV outbreak, which is just sadder than sad, because 40 years into this epidemic, we know better, right? We know what we need to do. It's what you were saying. It's moral, it's moral injury, actually. And I'm wondering if, I know the closure of the local syringe services program, which I had visited and which I thought was really quite wonderful. I know that closure is relatively recent. I wonder if you have begun to see any impact of that, or what important, especially to us, is what are your thoughts about galvanizing the community and trying to somehow take up the space or limit the harm of the loss of that syringe services program?
Yeah, fortunately, our commissioners gave us until January. So it did not close immediately. We're just impending the close in January. So right now we're kind of figuring out what we're going to do, whether that's above ground or underground, and just really making sure that whatever's done remains connected within that system of care, that the people that access the syringe service program, whatever that looks like, also is able to access, prevention services, treatment, and then all those psychosocial services that they need access to.
Okay, so you're hoping that providing enough wraparound services will sort of take up some of that slack.
Yeah, there's gonna, if we're not able to do something legitimate, we know there's going to be an underground. We're too well known for that not to occur. There's going to be, people to come in to do the right thing by providing people access to syringes. We want to explore the downstream ramifications of that. Does that increase syringe litter because there's no one collecting them? And how do we then respond by bringing more access to disposal sites in a way that doesn't put our agencies at risk, too? Because we we don't want more syringes on the street just because they closed the syringe service program. That's going to do the opposite, but that's what they didn't listen to us about. So it's, puts it back on us to clean up their mess in a way. So we're trying to figure that out, and then also trying to figure out, if underground groups do come in, how do we stay connected to them, and make sure that people that they're working with on the streets still feel safe accessing the care that they need. And so we're still trying to explore that.
Well, great. We hope we can learn from you.
I think secondary, just in a system where it's illegal to distribute syringes, it seems like secondary syringe distribution may be a good answer. And I visited a site in Indianapolis that does that. They actually have basically a text number through Google or something that people on the street can text and just leave a list of what they need. And then somebody, boxes that up in an inconspicuous package that doesn't look like syringes, drops it off to somebody. And then that somebody then is the one that actually distributes the supplies and the syringes. And then that model is great to get the syringes out there, but how do you get them back, picked back up? And then how do you still make sure people are getting tested and, getting on PrEP and getting treatment and those sorts of things? So there's complications with that, but if it's illegal, that seems like a good way to protect the agency from the laws while still getting people the syringes that they need. the supplies.
Great, thank you.
I feel weird talking about this so publicly, but
No, sadly, it's necessary. And we have our county now where our most active HIV outbreak is,
right.
on top of the state law, passed an ordinance that actually makes, that has criminal penalties. The state law only had civil penalties. So now in Charleston, our capital, will be criminal penalties for syringe distribution and things like that. It's wow, so wrong-headed, but so wrong-headed.
Yeah, we're in a climate where public health experts are not listened to on a number of fronts. And all we can do is, I think, just share the information, try to be the voice of reason, and hopefully enough people listen that we can get public opinion, behind the right course of action. Obviously, closing access points are going to, worsen the situation. We all know that. The public needs to know that. But it's also going to worsen syringes on the street, because if people, again, if they don't have access to disposal, just like smoking, you look at an area that doesn't have those places that you can dispose of the cigarette butts, they're all over the ground. Look outside of a restaurant. If they don't have those places where people can dispose of their buds, they're going to be thrown on the ground. Look at city blocks where there's no trash cans available. There's Polar Pop cups and straws. And when we go out to do street cleanups, we pick up more trash. I mean, it's almost all that we pick up. Bags and bags and bags of trash, and maybe 2 syringes. It's the same issue. If somebody doesn't have a place to get rid of the stuff that they have in their hand at the time, oftentimes it gets just thrown on the ground. So I think people should be able to understand that on some level. If you don't want syringes in the street, increase disposal sites. People who have diabetes needs those as much as anybody else. So it'd be a public health service for multiple people, not just people who inject drugs.
Dr. Cook, hey, John Gilfus, one of the infection docs here. Incredible presentation, man. You should run for office, by the way. I'd vote for you. I'd move to Indiana, or maybe I'd vote illegally. But incredible story. Austin was really lucky to have someone like you there, and appreciate your compassion and your empathetic perspective. It'll make me a better doctor, at least for today, hopefully long term. But we're all educators here. A lot of us are. My question is, clearly you have 77% of your patients undetectable. And you mentioned ECHO and Maytech. Those are wonderful education resources, but they're slow, intrinsically slow. And so I wanted to know how you got up to speed. Did you have an externship, or did you already have an interest ahead of time in training ahead of time in HIV and Hep C care? I'm just curious how you did this so quickly, got up to speed on HIV care. We would love to emulate whatever model people use to train you, because I think we're going to run into that in the southern part of our state quickly.
Well, first, thanks for the kind comments. That was very, very nice. I'm not sure about public office. That sounds terrible. But to answer your question, I found some mentors. Dr. Steve Norris in Indianapolis, he treats thousands of people living with HIV. He made himself available to me anytime. I could call him, text him, email. There were a couple doctors from IU Health that came down to the clinic once a week that I was able to work alongside. Just reading as much as I could and looking at presentations and videos and just sucking in as much information as I possibly could. And what I found was I was scared to treat HIV because I was trained the end of the 1990s. It was really complicated. There was a lot of drugs, a lot of interactions, all that stuff. And I was scared of it, had no interest in treating HIV. But then as I was working alongside these doctors, listening to Dr. Steve Norris, reading the guidelines, really found that for the most part in naive patients, it's pretty simple to start somebody and to treat somebody. It seemed to me like the biggest issue was just maintaining them in care. And so I felt like if I could develop some protocols that my staff was really simple to follow. These are the baseline labs I need. These are the medications we would start based on that, or we would do a rapid start now. Here's the follow-up, and just make it really regimented so all of my staff could easily understand it. And we could all get behind that pretty simply, and then focus most of our attention on retention and care, making sure that the patients felt safe to call us anytime, that we were going out and checking on them. Actually, my staff goes out into the community. If they've not been there for a while, we try to go find them and make sure that they're okay. So we focused mostly on the psychosocial, the needs, making them feel safe, that they belong, the access part. And as far as the actual treatment, just, getting that, I developed an algorithm on that. And yeah, it took another year or so to really understand the different classes of the antivirals and, the kind of the ins and outs of all of that. But as far as just getting it up and going and implemented, we did do that rather quickly. And it was really based on algorithms and just listening to mentors and trusting that they were right, and reading the guidelines and just making sure that those guidelines were right, and then catching up on the knowledge side of it on the other side. Hope that answers your question.
Oh, it's a beautiful answer. And
Okay, good.
How did you find that mentor? And you're so right on.
Maytech.
Social. It's Maytech. Okay.
Yeah, they linked me with Steve, with Dr. Norris. Yeah. Our Maytech has a clinical scholar program. I'm not sure if yours does or not.
We do. Yeah.
Great. Okay. Yeah, they link you with a mentor, and yep.
And that's beautiful. Great answer. Yeah, and you're so right on. It's not the pills. That's the easy part. It's the psychosocial adherence and all the other stuff. So much appreciated. The follow-up question: have you had much luck with your patients who inject drugs and PrEP? We've had incredibly low uptake.
Yeah, us too. MSM population, we do have quite a few people that have come to us, and we provide PrEP in that setting. We try for people who are injecting drugs. It seems like until they acquire HIV, it's not on their radar. It should be, but they're dealing with so many other issues. That's not one that raises up to the level, unless they're dating somebody living with HIV, and then all of a sudden it does, because they want to have sex and they know it's safe with PrEP. But yeah, same issue. If people are injecting drugs, low uptake on PrEP here as well.
Agreed. Thank you.
Yeah.
Thank you all so much. This has been wonderful discussion. Were there any other comments or questions for Dr. Cook?
Thank you so much for speaking to us. I just really appreciate it.
Oh, absolutely. I love doing this work and talking about it and all of that. And thank you all for doing this work as well. It's one of the reasons I wanted to do this, is I really admire what you're all doing. And I know how hard it is, and how lonely it feels, and how frustrating and futile it feels sometimes. But it's worth it. And I know you're all doing amazing work. So I want to tell you thank you for that. And I'm available, if you all have questions, or want to talk about things, or you have other churches or groups or community organizations, that'd be willing to talk through these issues and really to try to connect with people. I'm willing to do this more with other groups as well. And I hope you've looked at my book and maybe get that out to other people too, because I hope that it was written in a way that allows people an easy entry into the story. And then once they're into the story, really understand what it is to live off the grid, to live disconnected, to live under all this trauma, and maybe develop more empathy and understanding and willingness to, do something for people.
Thank you so much, Dr. Cook. And I'll absolutely attach your PowerPoint in the recap email that I send out. So all these participants on the ECHO call today and everyone on our listserv will be able to access that as well. So, and yeah, Elizabeth and I are not clinicians, but we feel so honored to be able to be part of ECHO and interact with you all. It's such an incredible platform. And I was so excited to see that you're familiar with Project ECHO before joining us today too. So
Yeah.
That was awesome. And we were getting some chats in as well. Thanking you. Great presentation, very inspiring. And thank you for being such an inspiration and for your example of compassion. So just wanted to read that out loud and relay those messages. So, all right. Were there any other comments or thoughts from the group? We have a few minutes left here. And before I jump into the announcements and the poll, I just wanted to give anyone another chance to speak up or chat in. All righty. Well, thank you again, Dr. Cook. This has been such a wonderful session, and we really, really appreciate your time coming here today and sharing your experiences with us. So I will get into the announcements now, and then right after that, I'm going to launch a voluntary poll. It's just a way for us to see how we can improve our sessions moving forward. So no pressure to take the poll, but I'll be launching that. And anytime you submit that, you can feel free to log off. The only announcement that I have is that our next session will be on August 26th, and Jared Coffey will be presenting on teleprep. So I'll be in touch with you, Jared, sometime in the next couple of weeks here. Let me launch this poll.